Hello, and welcome to 5-Minute Pediatric Nephrology. My name is Dr. Nephron because anything saltier would be bad for your health. Today we are going to learn about thrombotic microangiopathy, TMA, all in about 5 minutes, but don't hold me to it. So, how do we define TMA? Well, it's important to remember that TMA is not an actual diagnosis. Just like nephrotic syndrome, which is just the presence of albuminuria, low serum albumin, and edema, while minimal changes is diagnosis, TMA is a description of a constellation of symptoms. There are different diseases that fall under the TMA umbrella. Their features of TMA is a triad of microangiopathic hemolytic anemia, thrombocytopenia, and organ injury, with the kidneys most commonly affected. TMA can be divided into primary and secondary TMA. Classification schemas do differ, which we'll see shortly. The epidemiology of TMA does differ between pediatrics and adults. In the pediatric population, primary TMA, the most common cause is Shiga toxin E. coli HUS, followed by atypical HUS. Congenital or acquired TTP is fairly rare. The median age of onset is around 2 to 5 years old, but that does depend on etiology. And the mortality is around 10 to 15%, but again, that does depend on etiology. Secondary TMA includes things such as transplant-associated TMA, for example, those undergoing stem cell transplant, as well as some medications can also develop TMA. The pathogenesis of microangiopathic hemolytic anemia in TMA does depend on the underlying diagnosis, but the commonality is endothelial injury, leading to microvascular thrombus formation, and essentially high shear stress and turbulence for the red blood cells to pass through in the microcirculation, leading to red blood cell destruction and thrombosis. You can see some of the different etiologies in the bottom left corner. Because of the red blood cell destruction, you have elevated markers of hemolysis, like LDH, low haptoglobin, and Coombs may or may not be positive depending on the etiology. You may also see schistocytes on the smear. From a classification standpoint, there's really no standardized TMA classification. What is primary? What is secondary? But here's one schema you can think of, where again, TMA is the features of hemolytic anemia, thrombocytopenia, and kidney injury. And the causes are something like TTP, HUS, which could be divided into Shiga toxin HUS and atypical HUS. TTP could be hereditary or acquired. And secondary TMA, like we talked about, transplant-associated TMA, also includes certain medications can be involved. Also some other conditions, such as lupus, can all be causes of TMA. We previously touched briefly on some of the lab findings, anemia, thrombocytopenia, and AKI. There's a mnemonic called ATR, anemia, thrombocytopenia, renal involvement. Some of these supporting labs with evidence of hemolysis, such as an elevated LDH, which is a sign of cell turnover. Looking at the smear, which you would actually have to request to be prepared, and looking for schistocytes of the broken red blood cells. Haptoglobin, which would be low, since haptoglobin binds to free hemoglobin, and when the free hemoglobin increases, the haptoglobin level decreases. And of course, the reticulocyte count will be elevated as there's no bone marrow failure. As a feature of kidney injury, patients can present with hypertension, oftentimes oliguria, fatigue. If there's fever and neurological symptoms, which is more concerning for TTP, and again, that's a cause of TMA, however, there's a lot of significant overlap between TTP, atypical HUS, typical HUS, so just making the diagnosis of TTP based on the fever and neurological symptoms is not a given. There is a mnemonic for that, FAT-RN, fever and anemia, thrombocytopenia, renal failure, and neurological symptoms. Here we will go through some of the different causes of TMA. While we will address all of these in depth in other lectures, here's a brief overview. In HUS, typically Shiga toxin HUS, commonly associated with diarrhea, though that may be absent, and atypical HUS is complement deficiency, though they may also have diarrhea. TTP has low ADAM TS13, and we'll talk about that in another lecture. We discussed TTP and fever and neurological symptoms, which is not a good differentiator. However, TTP, commonly the platelets are very, very low as compared to HUS, which may help. Complement is typically lower in atypical HUS, and again, we'll have a separate lecture for that. The point is the treatment definitely differs between all these three, so it's very important to differentiate and then make the correct diagnosis so that you can make the correct management decisions. And so here we have a sample case. 7-year-old boy with fatigue, pallor, and decreased urine output, had bloody diarrhea a few days ago that is now resolved. Physical exam is significant for mild edema and hypertension. His labs, he's anemic, mildly thrombocytopenic with significant AKI. LDH is elevated, haptoglobin is low, indirect bilirubin is elevated. Schistocytes on the smear, Coombs negative. Stool is positive for shigatoxin. ADAMTS13 level is normal, and C3 is mildly low. Most likely diagnosis is typical HUS. Leading us to that diagnosis is the diarrhea and AKI. Normal ADAMTS13 rules out TTP. However, remember that ADAMTS13 does take a little while to come back, and we'll talk about that in another lecture. The C3 being low can still occur in typical HUS, so don't get thrown off to think it's atypical HUS. With a shigatoxin positive, diagnosis is most likely typical HUS. In terms of the treatment algorithm for TMA, you want to rule out TTP with an ADAMTS13 level. HUS, the treatment is supportive care. Atypical HUS is something called eculizumab. And for TTP, is plasma exchange. So again, it's very important to make the correct diagnosis. The complications associated with TMA do vary depending on etiology. AKI can lead to CKD. Depending on the etiology, up to 50% of patients can require acute dialysis. Neurologic involvement is significant and could be chronic depending on the etiology, and mortality is around 5 to 15%. Some of the key points: TMA is endothelial injury syndrome, triad of anemia, thrombocytopenia, and AKI, plus fever and neurological symptoms in TTP. Different etiologies require different treatments, and early diagnosis improves outcomes. On this last slide, we have some of the references that are applicable if you would like to take a deeper dive on the topic, because who wouldn't? That's your 5-minute pediatric nephrology on TMA with Dr. Nephron. Until next time, you're in good hands with renalforresidents.com. And don't forget to like, comment, and subscribe. And for more updates, you can follow us on our Instagram channel, Renal for Residents. Take care.